Well, good morning, everyone. I am Ruby Nguyen. I'm an associate professor here in the Division of Epidemiology and Community Health. I have the great pleasure of welcoming you to our division seminar series. First, let me begin with a land acknowledgement, particularly for those of you who are guests to our school. The University of Minnesota School of Public Health is located on traditional, ancestral, and contemporary lands of the indigenous people. The university resides on Dakota land ceded in the treaties of 1837 and 1851. The Division of Epidemiology and Community Health acknowledges this complex and layered history. This land acknowledgement is one of the ways in which we work to educate the campus and community about this land and our relationships with it and each other. The division is committed to ongoing efforts to recognize, support, and advocate for American Indian nations and peoples. So welcome again. This seminar is an important topic and one that I want to thank not only the faculty for getting together, but also the students. When the Dobbs decision came out in late May, early June, there was a lot of discussion within our division, as well as our school, about how best we could, as public health practitioners, as well as citizens, address what we were seeing in our nation and the changing scope of reproductive rights. And so as a part of that, we met several times over the summer to discuss where we want to go as the division and what to do next. And one of the things that came up was a discussion about how difficult it is to look at the epidemiology of something like induced abortion in the United States. That there was a plethora of information and data available, and quite honestly, that there wasn't enough training to prepare future epidemiologists to research something like induced abortion and reproductive rights. So at that same time, the Society for Epidemiologic Research had put out a statement on their vision about women's reproductive rights, as well as epidemiology training in this area. And through that, I was so happy to hear about the work that Caitlin Gertz has been doing. So we're pleased to have her here today. Dr. Caitlin Gertz serves as the Vice President for Research at IBIS Reproductive Health. She is an epidemiologist by training, whose research has included clinical and epidemiologic studies conducted in close partnership with abortion activists and feminist accompaniment groups on self-managed abortion, access to abortion in restrictive legal contexts, and abortion after 12 weeks of pregnancy. She holds a BA from Stanford University, a master's degree in health sciences from Johns Hopkins Bloomberg School of Public Health, and a PhD in epidemiology from the University of California at Berkeley. And today she's joined us to speak about the public health imperative of abortion access. Thank you, Caitlin, for spending the time. You've been so gracious with your time and expertise this morning. We are also actually very pleased to have you speak with our trainees after this seminar. So welcome, Caitlin, and thank you so much.
Thank you so much, Dr. Nguyen, and good morning to all of you. I'm going to share my slides and get started, but I also just want to apologize for the quality of my voice. I'm getting over a bug and I'm quite hoarse, so I hope I'll be able to be understood, but please stop me if you can't hear me. Give me just a second to set things up. Okay. Can you still see my slides, or are you looking at my script?
We're looking at your slide. And if
Okay,
you
great.
have technical questions, let us know if we can help.
Thank you. Okay, great. So apologies for the quick technical delay, but hello and good morning to all of you. My name is Caitlin Gertz. I'm the Vice President for Research at IBIS Reproductive Health. And I want to welcome you all today and also thank the organizers for the opportunity to be with you. Before we dive in, a bit about me. As Dr. Nguyen mentioned, I'm an epidemiologist by training, and I have spent my career focused on measuring, understanding, and evaluating interventions that seek to expand access to abortion, primarily in restrictive legal contexts. The organization where I work, IBIS Reproductive Health, is a nonprofit research organization with offices in Cambridge, Massachusetts, Oakland, California, and Johannesburg, South Africa. IBIS conducts rigorous clinical and social science research, most often in partnership with community-based organizations and service providers that seeks to advance sexual and reproductive autonomy, choices, and health worldwide. So today, in the hour that we have together, I'm hoping to talk about the context of abortion globally and in the United States post-Roe. We'll talk about sort of a 101, what is abortion? We'll talk about the epidemiology of abortion, its safety, effectiveness, and incidence. We'll also center and ground ourselves in the fact that abortion is a fundamental public health issue. We'll take stock of the current state of abortion in the US, and then we'll do a bit of looking ahead. So, to start us off, abortions are extremely safe procedures with few medical adverse effects. Indeed, abortion is safer at any gestation than pregnancy. A definitive 2015 study of 55,000 abortions that took place in the state of California determined that major abortion complications occur in less than 5% of abortions at any stage of pregnancy. And complications measured as any additional care received, including a visit to the ER, occur in approximately 2% of abortions. A landmark report from the National Academy of Sciences in 2018 examined decades of clinical, epidemiologic, and social science evidence and concluded that abortions are provided in the United States are overwhelmingly safe and effective. Just to give us all a bit of grounding in what abortion entails, both medical and procedural methods are recommended by the WHO, the American College of Obstetrics and Gynecology, and many other professional bodies for abortion. Sometimes abortion is referred to as induced abortion, as Dr. Nguyen did in her introduction, which distinguishes induced abortion from miscarriage or spontaneous abortion. The recommended protocol for abortion differs by the duration of pregnancy. Based on a robust body of clinical evidence for pregnancies below 12 to 14 weeks, the recommended procedural methods are manual or electric vacuum aspiration. This is a simple procedure which uses the suction of a syringe to remove the pregnancy tissue from the uterus. A thin tube is guided through the cervical opening to the uterus. The syringe is attached to the tube and used to remove the contents of the uterus. It usually takes less than 10 minutes. Medication abortion, also called the abortion pill or pills, involves either one medication called misoprostol or two medications, misoprostol in combination with mifepristone, and causes a procedure that is much like a miscarriage. Misoprostol is usually dissolved under the tongue and mifepristone is swallowed. Both regimens, one medication or two, are safe and highly effective. Later in pregnancy, The recommended surgical method is dilatation and evacuation using vacuum aspiration and forceps. Medications can also be safely used for abortion throughout pregnancy. People access abortion through and have preferences for a wide range of models of care, including clinic-based models where available and desirable, which include abortion care, instrumented or medication provided by a clinician in person at a permanent clinic or a mobile clinic, remotely through telemedicine or remote support from at-home administration of medications. Pharmacy access, where people access medication abortion through a pharmacist or drug seller without a prescription, and self-managed abortion, which can be defined as any action a person takes to end a pregnancy without clinical supervision. I'll talk a lot more about self-managed abortion later in this talk. Abortion is a common experience shared by many people around the globe. This graph is from a 2020 study by the WHO and the Guttmacher Institute that sought to estimate abortion incidence, technically a one-year period prevalence proportion. But since most researchers and people who consume abortion research aren't epidemiologists, we generally refer to this as an abortion rate. Across different regions, globally, in this study, they estimated the annual abortion rate to be 64 abortions per 1,000 women of reproductive age, which roughly corresponds to 73 million abortions each year. This study found that there were no appreciable differences in the abortion rate between the countries where abortion is legally protected and those where it is criminalized, underscoring that outlawing abortion, in fact, has no impact on the incidence of abortion itself. As our focus today is on the United States in a post-Roe world, I'll dive in a little more to what we know about abortion incidents in the US over the past nearly 50 years, which, to be clear, is the period of time when we have reliable data on abortion. Since 1973, the constitutional decision of Roe v. Wade enshrined protections for abortion access, making legal abortions available across the country and data more reliable. This graph, also from the Guttmacher Institute in New York, plots the total estimated number of abortions in the US for each of the years since 1973 through 2020. In 2020, the most recent year for which we have national data, there were an estimated 1 million abortions in the US, 930,160 abortions to be exact. In 2020, this total number of abortions translates to about 1 in 5 pregnancies ending in abortion, aka the abortion ratio, which is the number of abortions per 100 pregnancies, which in 2020 was 20.6%, a 12% increase over 2017. To a Zoom room full of epidemiologists and public health students and practitioners, it's worth pointing out that abortion incidence is really hard to measure. There are no CDC reporting requirements about abortion, and measuring incidence will only get harder as more abortions in the United States shift to outside of the public health system and cannot be captured by traditional data reporting or research. There are many different strategies that researchers have used across the globe to try and estimate abortion in places where the majority of abortions take place outside of the formal healthcare system. Some of these methods include the list experiment, which is a way of anonymously reporting abortions that has been translated to public health from political science. People have used the abortion incidence control method, RDS, and a variety of other network-based reporting methods to try to get a more reliable understanding of abortion incidence. I'd be happy to talk about some of these methods later on. In terms of who has abortions in the United States, the short answer is all kinds of people have abortions. The more data-driven answer, though, is that about 1 in 4 women will have an abortion in their lifetime in the United States. And I also want to be very clear about my language. You will hear me talk about pregnant people and people who have abortions. And from the best data that we have, we know that at least 500 trans and non-binary identifying people have abortions each year in the United States, which is absolutely an undercount because of the way that we have classified and tried to collect data on people who do not identify in the gender binary. Most abortion patients are in their 20s, with the highest single age group in their late 20s. Most abortion patients are parents. 59%, in fact, already have children. Most are struggling to make ends meet. 75% of people who have abortions report having incomes below the federal poverty level. Most identify with a Christian faith, 54%, and about half, 51%, used a contraceptive method in the month that they became pregnant. Abortion patients identify as white, Black, Hispanic, Asian or Pacific Islander, and many other races and ethnicities. So, given the context of how many abortions take place in the US, I also want us to take a look at the overwhelming public health evidence that affirms the large, profound benefits that abortion holds for people's lives. As a starting place for this conversation about the role in public health, some history is critically important. In the United States, in 1994, Black women social justice leaders created the framework of reproductive justice. Reproductive justice is a movement that firmly is grounded in human rights principles and sees abortion and other reproductive health services as resources that everyone is entitled to, such as healthcare, education, housing, and food. Reproductive justice is a contemporary framework for activism and holds the following principles. First, the right not to have a child. Second, the right to have a child. And third, the right to parent the children we have in safe and healthy environments. Abortion is a key component of ensuring that these rights are met, but it is a part of a much broader framework. The rights enumerated in the reproductive justice framework are fully validated by the overwhelming evidence on the public health benefits of abortion. I've already highlighted the data on safety and effectiveness of abortion methods, and I'll now focus on some of the other seminal epidemiologic and social science research that has measured the effects of obtaining or being denied wanted abortion care. These benefits include dramatic reductions in pregnancy-related morbidity and mortality. And of course, it's really important for all of us to remember that the counterfactual outcome for someone who does not obtain a wanted abortion is not just that they remain pregnant, but rather, for most people, results in giving birth. While abortion is extremely safe at any gestation, pregnancy and birth confers a relatively high risk of death or temporary and permanent inabilities, particularly in a country with high maternal mortality and morbidity and shameful disparities across racial and ethnic lines, where Black birthing people are nearly 3 to 4 times as likely to die in childbirth. Thus, denying someone abortion care directly increases the risks to their physical health and safety. Beyond reducing the risk of pregnancy-related morbidity and mortality, research also concludes that people who get abortions have an increased ability to set and achieve educational, career, and family goals, a greater likelihood of escaping poverty, better developmental outcomes for current and future children, increased likelihood of leaving abusive relationships, and much more. All of these benefits have been repeatedly demonstrated across epidemiologic and other research on receipt of abortion versus denial. I want to now turn to a seminal study led by PI Dr. Diana Green Foster at the University of California, San Francisco. Researchers have studied abortion and its role in public health in different ways, but this study, led by Dr. Foster and a team of brilliant abortion researchers, gives us a sense with a clear comparison group of what the impact on receiving versus being denied abortion looks like in the United States. So just a bit on the Turnaway study. It was a prospective study that utilized a pseudo-natural experiment regression discontinuity design based on variation in state gestational age cutoffs for abortion. In the study, which was conducted between 2010 and 2016, researchers measured the effects of receiving versus being denied a wanted abortion for the pregnant person and their children. Nearly 1,000 women seeking abortion from 30 facilities around the country participated. Researchers conducted interviews over 5 years and compared the trajectories of the participants who received wanted abortion to those who were turned away because they were past the facility's gestational age limit. Over 5 years of research, the findings are striking about the benefits of receiving abortion and the harms of being denied abortion. They indicate that participants who did not obtain a wanted abortion were more likely to experience serious complications from the end of pregnancy, including eclampsia and in some cases death. They were more likely to stay tethered to abusive partners because they had a child together. They were more likely to suffer anxiety and loss of self-esteem in the short term after being denied wanted abortion. They were less likely to have aspirational plans for the coming year and less likely to achieve their life goals over the 5-year period. They were more likely to experience poor physical health for years after the pregnancy, including chronic pain and gestational hypertension. The study also finds being denied abortion had serious implications for the existing children and subsequent children born to people who were denied abortion. Serious socioeconomic consequences were documented as well. People who were denied a wanted abortion were 4 times more likely to live below the federal poverty level than their counterparts who obtained a wanted abortion. And they had 3 times greater odds of being unemployed. In addition to the Turnaway study, much epidemiologic and social science research has focused on measuring the harms of policies that restrict access to abortion care, whether they are policies related to gestational age limits, restrictions on insurance coverage for abortion, parental involvement laws, targeted regulation of abortion providers, and much more. This body of research, which I cannot emphasize how extensive it is, consistently and strikingly finds that these restrictions on abortion access harm pregnant people and their families. In short, in nearly every way that abortion has been studied, we see that being able to obtain abortion care is beneficial for individual and public health, and that restricting access to abortion care is harmful at individual, family, and community levels. So how did we get here? The current state of abortion in the US is the culmination of decades of increasing restrictions on abortion at the state level. In 2021, 108 state-level abortion restrictions were passed. The type of restrictions passed at the state level have generally fallen under four broad categories. First, abortion bans, banning abortion gestational age limits. Second, restrictions on medication abortion, explicitly prohibiting telehealth medication abortion, placing restrictions on what gestation medication abortion can be used, despite its safety and effectiveness throughout pregnancy. Restrictions called trap laws, targeted regulation of abortion providers, which are geared at forcing abortion clinics to close by passing restrictions that require things like hallways in clinics to be a certain width, or requiring providers to have admitting privileges at the nearest hospital, despite the very low likelihood that their patients will need to be admitted to a hospital. And finally, restrictions focused on the individual's experience, including waiting periods, forcing people to wait 24 or 48 hours in between their first appointment and their abortion, forcing people to view an ultrasound, forcing providers to read medically inaccurate information about the risks of abortion, and many others. Ultimately, the goal of these restrictions is to chip away at abortion access at the state level in the absence of the ability to completely ban abortion. As a result, the last few decades of public health research on abortion access in the United States has been geared towards the courts and regulatory bodies to document the impact of these restrictions. For example, research documenting the impact of clinic closures on driving to clinics, research on the long-term impact of being denied an abortion, research on whether different providers can dispense medication abortion safely and effectively, research on the impact of denying health insurance for abortion, research on the safety and acceptability of telemedicine for abortion, just to name a few. It is true that there have been some wins. In 2016, Whole Women's Health versus Hellerstadt in Texas, and June Medical versus Rousseau in Louisiana in 2020. The Supreme Court ruled that the state-level abortion restrictions posed an undue burden on people seeking abortions and ruled they were unconstitutional under the precedents by Roe v. Wade and Planned Parenthood versus Casey. These are great examples of the use of research in informing policy. Both cases heavily cited public health research documenting the harms of laws in these opinions. Unfortunately, though, research can't be used to inform policy decisions if the overarching framework that research is conducted, namely constitutional protections for abortion, no longer exist. As you all know, on June 24th, the Supreme Court issued their decision on the case Dobbs v. Jackson versus Women's Health. This was a case brought by Jackson Women's Health Organization, the sole abortion provider in Mississippi, challenging Mississippi's 15-week ban on abortion. The ban was passed in 2018, but was under injunction, so not allowed to go into effect. In their ruling on the case, not only did the court's conservative majority hold that Mississippi's 15-week ban could go into effect, excuse me, they overturned Roe v. Wade and Planned Parenthood versus Casey, arguing that the US Constitution does not confer a right to abortion. and giving the full power to regulate abortion back to the states. This decision was widely condemned by civil rights organizations, reproductive rights organizations, the United Nations, the World Health Organization, and many professional bodies. So where are we now? The overturning of Roe v. Wade, states that are hostile to abortion access no longer need to slowly chip away at access. They are fully empowered to pass abortion laws that not only ban access to abortion, but also criminalize people seeking abortions or those who support them. Since the Supreme Court decision, we have seen many laws go into effect. Clinics in states where there are pre-Roe bans had to rapidly close out of concern for legal repercussions as the laws get argued in state courts. Clinic-based access changes day by day. So I want to say the best resource for up-to-date information about where abortion is legal is this map that is created by the Center for Reproductive Rights. This map is from 2 days ago. States that are displayed here in dark red have current bans in effect. Those in lighter red are hostile. Either they have bans not yet in effect, but are likely to go effect, or they have 6-week abortion bans, which in essence bans abortion before most people know that they are pregnant. Those displayed in yellow here are states with laws that protect or affirm the right to abortion. However, even in the protected states, that status can be misleading, as some of those states have gestational limits, like Florida, which has a 15-week abortion ban, and other restrictions like those that I've talked about, mandatory waiting periods, and others that make abortion more difficult to access. Only those in blue, like Minnesota, are those that have passed legislation to expand access, such as providing state insurance coverage for abortion, allowing for telehealth, expanding the cadre of medical providers that can provide abortion, and protecting providers that might seek to support people providing in other states. So where are we headed? Well, things change daily. For example, just yesterday, the Indiana Supreme Court upheld a stay on their abortion ban, keeping abortion legal in Indiana for now. It is most likely that all of the states in red on the previous map will eventually succeed in banning clinic-based access to abortion in the coming months. This graph from the New York Times shows the decline in legal abortions once clinics in the red states closed, with Black representing a 40% decrease in legal abortions. And it's hard to know the impact on other reproductive health or broader health issues this ruling will have. It's clear that people are already being criminalized or threatened with criminalization for having an abortion, and people are being denied timely care for miscarriage, ectopic pregnancies, and other pregnancy-related complications out of an abundance of fear for the penalties for providers and healthcare systems. But what is it really going to look like in the coming months and years? Data from Texas can provide some guidance for the impact on total abortion bans, on providing an abortion experiences and trajectories. Just over a year ago, September 1st, 2021, Texas Senate Bill 8 went into effect, which at the time was the most restrictive abortion bill in the country. Many of you may have seen this graph in the New York Times, denoting the impact of SB 8 on Texas access to abortion. While the article was titled, "Most Women Denied Abortions by Texas Law Got Them Another Way," either traveling out of state via online telemedicine pharmacies or before 6 weeks in the state, the reality behind this graph is far more complicated. First, Research from the University of Texas at Austin documented that in the month following the implementation of SB 8, the number of abortions in Texas fell by half compared to the same month in 2020. And even while many Texans may have gotten abortions, there was still a dramatic decline in abortions from March of 2021. It's also important to remember that just because people requested abortions online does not mean that they were all able to get them. And while many people traveled out of state, travel is not an option for many people who have child care responsibilities, elder care responsibilities, people who have jobs where they can't miss 2 or 3 days of work, adolescents who can't leave home. Not to mention that among those who traveled in Texas, most went to Oklahoma, where abortion is now completely banned. Critically, the graph minimizes the tremendous effort that people working on the ground in abortion funds and clinics at the grassroots level to ensure that people get care. This is an unsustainable amount of effort, time, resources, coordination, and money that should not have to be expended for access to a simple medical procedure. Zooming out to the global context, while the direction of the US is wildly out of step with what global trends have been in decriminalizing and expanding access to global abortion, restrictions on abortion are not new. Around half of the world's population live in countries with restrictive abortion laws. And we know that while restrictions do not prevent people from obtaining an abortion entirely, they may prevent many, and it does not prevent abortion from continuing to happen even outside of legal context. While some proportion of the abortions that occur in restrictive legal settings are considered to be unsafe, a growing proportion of all abortions globally are self-managed medication abortions. So what is self-managed abortion? The most common definition is any attempt to end a pregnancy without clinical supervision. This includes safe and effective methods such as medications, or with less studied methods like herbs, or with methods known to be harmful, like ingesting poisons, chemicals, or physical trauma. Self-managed abortion itself is also not new. People have been self-managing their abortions for thousands and thousands of years, using a variety of methods. And it was pregnant people in Brazil who first discovered the use of misoprostol, which has many other medical indications as an effective abortion medication. In many restrictive countries, there are community-based groups and activist networks, often called accompaniment groups or safe abortion hotlines, that provide people with information and support on how to safely and effectively self-manage their abortion using medications. These groups fill a vacuum left by the state that has failed to provide safe abortion options for its residents. Given 20 years of research on the safety and effectiveness of medication abortion and a robust and growing evidence base on the self-use of these medications without clinical support, just last year, the WHO updated their abortion technical guidelines to fully recognize the role of the individual in their own abortion process and to fully recommend self-managed medication abortion using either mifepristone in combination with misoprostol or misoprostol alone as a recommended model of abortion care. However, despite confidence that self-managed abortion with pills is medically safe, many people still don't know about medication abortion as an option. They may lack the technical or medical literacy to navigate access to pills online or via other means. We know that people in the United States have, as people have everywhere, self-managed their abortions throughout our history. And people have and do use a range of methods to do so. We also know that people who self-manage abortion in the United States do so for a range of reasons, including in some cases a preference for avoiding interactions with a medical system that has discriminated against them or their communities or has otherwise not served their needs, but also because for many, clinical care is too expensive or too far away. As clinic-based care moves further out of reach for so many in the United States, research has shown us that many of the same communities who will be most impacted on by restrictive laws also face substantial barriers to access about information around self-managed abortion with medications, barriers which urgently need to be addressed. It is critical, though, that we all remember that although self-managed abortion is safe, effective, and can in fact be a positive, even empowering experience for some, the risk, especially for those seeking to self-manage an abortion in the United States under restrictive legal contexts, remains a legal risk. And as with all things, we see this legal risk disproportionately on people who are already overly policed, surveilled, and criminalized, namely Black people, Indigenous people, people of color, trans and non-binary people, immigrants, and other marginalized groups. So while medical safety is established, a lot of messaging and outreach is needed to raise awareness of ways that people can protect themselves against the risk of criminalization for self-managing an abortion, primarily by taking steps to protect digital privacy and communication to clinicians that they should never, ever report their patients who seek care during or after a self-managed abortion. Of course, we know that a law making abortion legal was never enough to guarantee access in America. Many individuals of the groups I just mentioned throughout the history of legal abortion in the United States faced immense barriers to accessing abortion care, and these new laws have only exacerbated and made those challenges in access greater. Already in the months since Dobbs' decision, we have begun to see the harms, the downstream effects on health and well-being for so many Americans now living without access to care. Reports from states or from clinics in blue states tells us that people are traveling, many of them, and clinics are overwhelmed. But not everyone can travel. Online abortion providers have seen a surge in demand for abortion pills from those in states with bans and from those in protected states. And of course, many people, too many people, are unable to get the abortion care that they need and will be forced to carry their pregnancies to term. There are new models of care that are emerging. Communities are coming together to take care of each other. Abortion funds and practical support organizations are stepping in to fill the cracks in the healthcare system that is faltering. All of this signals to me, though, that there is no silver bullet. There is no single solution that will solve the abortion access crisis, because abortion, simply put, is a fundamental component of reproductive health care, and there is no single substitute for a healthcare system that is failing to provide comprehensive care. So what do we do? What is next? What is our role as public health practitioners in this state of crisis? It's easy to despair, to be overwhelmed by the violation of public health principles that is unfolding in our moment, this country's history, or to feel paralyzed by the harms, physical and legal, that we know will occur and already are. But indeed, though we broadly understand what the harms will be, one of the roles of public health researchers must be to continue to document the harms, to continue to unflinchingly observe so that the harms do not become invisible. It is our role to be responsive, to listen to people on the ground, to learn from our partners globally, to continue to evaluate creative, innovative interventions that make things even a little better in the face of such challenge. And of course, to lay the evidence-based groundwork for a more equitable future, and a future that is based in the reproductive justice framework that allows people to make decisions about their own reproduction. Thank you so much.
Thank you, Dr. Gertz. One of the disadvantages of living through this Zoom world is that we can't show you our appreciation, but I've certainly been seeing it in the chat box. So thank you so much, particularly for this tour de force given your voice. So we're sorry that you weren't feeling well, but I'm very appreciative of you taking the time and effort, particularly getting over this illness. Dr. Gertz, actually, first to the audience, we welcome questions. I've received a few in the chat, but I'd like to invite more. So I'm going to start with the ones that we have. First, let me reiterate the amount of gratitude that I'm seeing in the chat box. So the first question is, with regard to the figure that you showed on states that are allowing abortion, the comment was they were glad to see that Minnesota is a turquoise state. We're wondering if you can answer this question, Dr. Gertz. What can we do to keep it that way? And I'm wondering if you can answer perhaps as a citizen, but also, or someone a citizen, global citizen, and then secondly, as a public health practitioner.
It's such an important question. And we are seeing the states in blue on that map take really creative, really interesting steps to help enshrine access and ensure that the states that are blue remain that way. Of course, one important thing to say is that making sure that you register to vote and support efforts to ensure that voting rights continue to be enshrined for all people. As I think about the ways in which our movement, the reproductive health rights and justice movement, are inextricably linked to the racial justice movement, the voting rights movement, it's really critical to remember that, telling people to go out and vote is one thing, but making sure that we protect the right to vote for all people is another core component to being able to exercise our role as global citizens. I think we can also look to states like Massachusetts and California and Oregon, where recent legislation has been passed, not only to enshrine the constitutional right to abortion in the state constitutions, but also expanding the right to protect those who might seek to support people from other states to obtain abortion. So encouraging your representatives, senators, legislators to think about more expansive abortion laws is something else that we can do. In terms of that second part of your question, Dr. Wen, I think, Minnesota has always been such a bastion of public health and a robust public health system. And I both want to encourage everyone on the call to think about that, to continue to resource your public health system. And I will say, as public health practitioners, all of us, to continue to talk about abortion as a public health issue. For too long in my career as an epidemiologist, I was told that abortion was a political issue and that it was too risky or political to study abortion as an epidemiologic topic. And I see a paradigm shift happening in the community, in the public health community, in the epidemiologic community, finally understanding that abortion has a critical impact on people's health and well-being. And so I call on all of you as public health practitioners to be as well-versed in the evidence around around abortion as you are in the evidence around smoking and its impact on public health. it is one and the same. It is a core component of public health, and it's our responsibility to talk about it as such, to normalize it, and to help make sure that it gets incorporated into the public health system, the primary healthcare system in Minnesota and in other states.
Thank you so much. So Minnesota is a very generally healthy state, but it is also a state of horrible dichotomy. So we have some of the worst health disparities indicators, particularly related to maternal and child health, that we as a school are invested in changing. But thank you for that. You and I have talked about how best to prepare the next generation of reproductive justice and reproductive epidemiologists. What you just said really has changed my focus on how we should be approaching, for example, not only all of public health, but maternal and child health education. What other recommendations would you have in updating our curriculum or our theories to preparing the next generation, particularly of epidemiologists, let's say?
I think it's an important question for this group, especially to consider. I think I would like to see core courses in, every school of public health that incorporate and teach about the epidemiology of reproductive health, including abortion, and that really dig into some of the methodologic challenges of measuring abortion incidence, access, and care. I see a question in the chat about abortion incidence and what it would take to encourage the CDC to mandate abortion reporting from every state. And I will say, I think that will never happen. And I say that because it didn't happen in the 50 years that abortion was legally available. But I do think that states where abortion is legally provided can do a better job of understanding what abortion incidents will look like. There's an effort currently underway by the Society of Family Planning that is trying to collect data, in essence, to replace the absence of CDC reporting from every clinic that is providing abortion in the United States. And it is a very simple effort. It is really just trying to understand how many abortions are performed. So if you know clinics that are not a part of that effort, please encourage them to reach out to the Society of Family Planning. It's the best that we can do right now to capture abortions that are happening within the constraints of the legal system. But I will also say, as all of my colleagues at SFB will say, it does not capture the abortions that are happening, that are self-managed, that are happening in other ways. And so thinking about what it looks like to try to understand what abortions can't happen because people do have access to self-managed abortion, and what abortions can't happen because people simply cannot access care is going to be one of the core methodologic challenges of our field in the coming years.
Thank you. So just to reiterate the question, it was, what would it take for the CDC to mandate abortion reporting? A related question is, what do you see as the role of local public health? So city and county level public health practitioners and units.
So there are two things. The first I'll say is, I'll reiterate the call to really incorporate abortion as a core component of public health. States and local governments can take steps to ensure that public insurance can be used to cover abortion. The cost of abortion is prohibitive for so many people. States and local public health agencies can also, even in red states, can take measures to defy the law. They can choose not to enforce some of the provisions of the law, they can attempt to enshrine some kind of access. And I think encouraging a wide range of cadres of providers, as we have seen in the data, the WHO now recommends self-managed medication abortion and support for medication abortion from everyone from community health workers who are not clinically trained to highly trained family planning specialists and OB-GYNs. So expanding the cadres of providers, of support people, and really encouraging public health guidance to follow the evidence so that we have providers within the primary healthcare system who are able to provide abortion care. Nobody should have to go to an abortion clinic to get an abortion. Their family doc can provide abortion care just as easily as somebody at an abortion clinic. So trying to incorporate abortion into the fabric of healthcare is one thing that I really see as a future where we're laying the groundwork for abortion to be normalized with the public health system and within the health system broadly.
Thank you. In this division, we're thinking about going bold. So this question asks, should those working in reproductive justice focus on reform or abolition?
I love this question. I saw an earlier question about the abolition framework. And I think as a public health practitioner and someone who has learned so much from the reproductive justice framework, there is no reproductive justice without abolition. And I think to the extent that focusing on reform.
I'm sorry, Caitlin, would you mind giving a primer on abolition as much as you are comfortable?
So I'm absolutely not the right person to give the definition. I would point everyone towards Sister Song for Reproductive Justice and many of Loretta Ross and her work. But essentially, the idea of abolition as removing the carceral system, abolishing the carceral system, and sort of doing away with the framework of reproductive health or anything having to do with reproductive justice intersecting at all with the criminal or carceral system, and thinking about racial justice and reproductive autonomy as one and the same. As a very poor explanation. I'm sure there are those on this call who would do a better job, but thinking about reproductive justice as a goal towards liberation, and especially Black liberation and liberation for all. And I think that it's critical because in the frameworks within which we work, we cannot think about these abortion restrictions without thinking about understanding the links between white supremacy and the anti-abortion movement. And so using an abolition framework, using a reproductive justice framework to think about all of our intersecting movements for social justice, for racial justice, economic justice, immigration justice, together as one whole is the only way that we will lay the groundwork for a liberated future where abortion is available to everyone who needs it, is a part of the healthcare system, and where people have the infrastructure to be able to support healthy, sustainable lives in safe communities.
Dr. Gertz, this was excellent. It was informative, it was reinvigorating, and it really gives us hope in training the next generation to address these as we do today. So thank you so very much for your time, and thank you in advance for meeting with our trainees afterward. So I can speak on, I think, on everyone's behalf. Thank you and best wishes on your work. Bye. Bye,
Thank you
everyone.
so much, everyone.